Okay, so thank you everyone for joining us in this urban lunch. Our urban lunches typically have between 100 and 150 people. Today we have almost 200 people that have expressed interest in joining us. I don't know how many of those will actually show, but obviously a great interest in this topic. One of the great tragedies, the great challenges of Vancouver is the drug addiction crisis. We have almost 12,000 people who've died of an overdose since 2016. And if that was in Switzerland, you'd be close to 20,000 people. I believe that, Switzerland's a bigger place in British Columbia. So I think our two guests would admit that we are having problems. This is not normal. This is not anything that's acceptable. We also have the problem, the challenge of the downtown east side. We have, I've been doing some research, and it was Judy Graves, who is one of the heroes of Vancouver, who has been saying that, one of the big problems is dealing with these challenges is the concentration of people in one area. And many people have said that for many years, but when Judy Graves says it, somehow I think it's more important we listen to that. So our global civic think tank is the host of the Urban Lunch, and we'll be releasing a video very soon that documents how the city shut down low-income market housing in all of the single-family neighborhoods of Vancouver, starting in around 1970s. Almost all of the rooming houses were shut down. Vancouver used to be full of rooming houses in which the people who owned a home, usually older women, actually, and they would rent out their bedrooms. They were basically SROs. And between 1971 and 1986, more than 90% of all these homes were shut down. And I know when Judy Graves did the very first homeless count in Vancouver, we didn't have street homeless in the way we do now, up until basically 1990 or 91. And so the very first street homeless count, Judy Graves was asking people, and many of them said they had their rooming house shut down in another neighborhood. So SROs became illegal everywhere in the city except one place. It's a place no one had ever heard this name. It was called the Downtown East Side. It had never been heard in public. It was a name that was used in the planning department and the social planning department of Vancouver. And that became then the core of this new neighborhood. It was actually a LIP grant, a federal grant, to hire 10 advocates to help advocate for this new neighborhood, this new concept. And basically, when you shut down and make illegal SROs everywhere except one neighborhood, I think it's pretty clear what is going to happen. Surveys show that the majority of residents who do live in the downtown east side say they would rather live in a different neighborhood or a different city. And so we feel that just by supporting residents in what they say they want to do would result in significant deconcentration. So the question is, has there been anywhere in the world that had large open drug scenes and they no longer have them? They were shut down, and in fact there is. It's a place called Switzerland, and the two gentlemen that probably did more than anybody else to bring this open drug scenes to a close and to move into a more integrated system of people in social integration and healthy mixed communities are with us today. And how honored we are to have these heroes, really, who have brought much healthier lives to so many people with addictions, and the country of Switzerland, and all of the cities. There were open drug scenes in many of the cities. So this lunch, urban lunch, we featuring Dr. André Seidenberg and Jakob. And now we're going to first hear from Dr. André Seidenberg. So he is a general practitioner, medical doctor, and that surprised me right away because I thought his expertise was in addiction. And in fact, it wasn't. He was a general practitioner, and there was basically a revolt by many general practitioners where the government wanted to go in one direction, and many of the doctors felt that this was killing people. So Zurich had Platzwitz Park, the largest open drug scene in Europe. And I've spoken to other medical people in Switzerland, and they do confirm that André Seidenberg is a hero. They said he risked much, including his own medical license, that the protocols that he wrote about dealing with drug addiction are still used. A doctor I spoke to said he still uses the protocols that were written by André Seidenberg 25 years ago. So I was able to talk to him. He was recently in Jerusalem. He's writing a book called Spinoza, Sucht and Thinking. Did I say it right? Sucht?
Yeah.
And this is where he deals with the philosophy of Spinoza. And, you know, Spinoza, this great Enlightenment thinker who was a relentless pursuer of the truth, even to the point of self-harm. He pursued the truth. And so I've read a little bit of the book where he weaves what he's learned about humanity through addiction. So André Seidenberg, Dr. André Seidenberg, thank you for joining us. Please make your presentation now.
Thank you very much, Sam, for the kind introduction. Yes, I want to talk about the opioid crisis in Zurich, Switzerland in the mid-80s to the mid-90s. Count Münchhausen, he asks himself how to get out of a swamp. Could I pull myself out by the own hair? The strength and power of a society can be measured by its ability to absorb and retain those on its fringes. Switzerland is in the heart of Europe. Switzerland is one of the richest countries in the world. Google's European headquarters and two top universities are in Zurich. Switzerland is a well-organized, tiny country between the mountains. We are about 9 million inhabitants. Most of the population lives in a megalopolis in a park-like landscape between the high mountains, which stretches from the Lake of Constance to Geneva. Switzerland, with the Latin name Confederatio Helveticorum, is a confederation of states, cantons with a constitution similar to the US. Do you see me?
Yes.
Okay. 1/3 are immigrants born abroad in Italy, Spain, Portugal, Turkey, Germany, the former Yugoslav states, and Ukraine. In addition, many expats with higher education, bankers, and scientists from all over the world live in Switzerland. Switzerland is able to integrate, its ability to integrate is high. Everyone has a health insurance. There are no large underclass neighborhoods with outcasts of homogeneous origin. Switzerland, and allow me to say Zurich in particular, are very beautiful places. This is Zurich beneath the fog early in the morning and the sunrise behind the Alpine mountains. Are you coming to Switzerland to see drug problems? You won't see them anymore. Before the 80s and again today, Blochspitz is a very beautiful and quiet park behind the main train station. Blochspitz Park became world famous as the most horrific drug scene. From 1968 to 1986, the police tried with all their might to suppress drug trafficking and drug consumption in the city of Zurich. Drug repression forces. Do you see me?
Yes.
Okay. Drug repression forces grew more than 100 times. In 1968, we had 2 police officers specialized in drug problems. In the 80s and the 90s, there were several hundred. Drug-related crime became the leading cause of incarceration in Zurich and in Switzerland. In regard to drug problems and HIV, Switzerland topped the European rankings. 1% of the young people born in 1968, they are now 55, but then they were young. They became opioid addicted in Switzerland, 1%. 3 out of 10,000 Swiss inhabitants were infected with HIV and many died from AIDS. Petty crime and prostitution were visible everywhere. Illegal use of opioids was the most important cause of death in the middle-aged population of Switzerland. Everyone knew someone who was affected. Out of sheer frustration, the police tolerated drug trafficking and drug use in Blochspitz Park from 1986 to 1992. There were no police, no public order, but crime of every kind. 24/7, 385 days of an illegal market for everything. The poorest and most miserable human beings were there day and night, and even in winter with temperatures as low as -20 centigrades. Up to 12,000 packages containing sterile needles and syringes were dispensed daily. Up to 25 resuscitations on spot per day. Outside the park, drug suppression continued as before, with zero tolerance for drug addicts. The problems spilled over the boundaries of the park and threatened public order of the whole city. Public order is hampered and disrupted by drug repression. Mafia and police are unable to organize a market that meets the needs of society and meets the addict needs adequately. In Bern, drug problems were dealt with more cooperatively than in Zurich. Establishing harm reduction for drug use was not easy in Zurich. State authorities wanted ideologically strict soldiers in the war on drugs. HIV infection and AIDS were new and frightening diseases. 1985 health authorities tried to prevent the obviously necessary dispensing of sterile injection needles and syringes. We 350 general practitioners stated that we are not wanting to follow this order. In Zurich, we started to ignore governmental guidelines. Laws, science, and our know-how were better. Tackling drug problems means to know what is the problem. What is the problem? And what can we do? We need to analyze the market, who is doing what, and why. Why is a junking acting like she or he does? What do we know? Addiction limits behavioral options. Depending on the type of drug, the range is huge. Unlike other addicts, an opioid addict has no choice but to satiate their opioid cravings daily or even multiple times a day. Withdrawal from opioids is torture, which affects the most existential features of well-being. It causes the greatest feeling of fear, pain, cold, loneliness, and discomfort imaginable. Looking at the animal in the experimental cage, it's easy to understand that no punishment or threat will effectively and permanently stop an opioid addict from looking for the next shot or hit. In the 1976 experiment, James Olds allowed the animal electrical self-stimulation or the direct release of opioids in the brain. Squeezing the lever triggers an electrical impulse or releases a small amount of drug in the reward system. Even a burning hot plate under its feet couldn't keep the beast away from the switch. An opioid addict has no choice but to satiate their opioid hunger again and again and again. The mesolimbic pathway ends in the nucleus accumbens. All addiction is rooted in dopamine release at the base of our cerebrum. Opioids, cocaine, alcohol, amphetamines, benzodiazepines, nicotine, THC, all addiction-causing substances, and also the endogenic opioid peptides, noradrenaline and GABA stimulate the same nervous system. All our desires, all we want, what we like, what is beautiful and true, releases dopamine in the nucleus accumbens. Closing Plotspitz Park didn't stop the public disorder and threat. Police forces with batons, tear gas, and rubber shotguns pushed the hundreds of opioid addicts through the city, even the wealthy inner city unable to disperse them. The scene gathered again on the tracks of the disused railway at Latin Station. The police had to tolerate them there until 1995. A specialized jail called Rückführungszentrum, a police hospital for drug addicts, collected 100 non-residents and transported them with buses to other cantons they had come from. The next day they were back in Zurich until they had a local possibility for methadone. Only then they were able to cope with help, medical treatment for their ailments, to stay and reintegrate. It took years until the end of century. The whole of society, including the police, the judiciary, all the repressive forces, understood it at the time. Drug repression, the blind suppression of drug trafficking, is not conducive to maintaining order. Enable and secure, organize a supply market in as orderly a framework as possible. That is the recipe of the Swiss drug policy in the 80s and in the 90s. In February 1992, when it had been closing Plotspitz Park, Arut opened the first low threshold methadone dispensing clinic. Arut, the Association for Risk Reduction in Using Drugs, was founded and financed mainly by the general practitioners with a private practice. Its costs are covered by the mandatory health insurance. There is no money from government. Our computerized dosing system allowed an individual dosing within the frames of safety. After 1 week, usually the saturation dose of 100 milligram methadone could be achieved. The model was copied in Zurich, other cantons, and abroad. Within a few years, a demand covering offer of low threshold methadone emerged all over Switzerland. Here, I go through fast. This is my career. Today, more than a half of the Swiss opioid addicts are in sustained care on opioid agonist therapy. Opioid agonist therapy is based on methadone, buprenorphine, morphine, Rotas, and a few on heroin. more have been in opioid-assisted treatment within the last months, but more as half of the population is in sustained care with opioid-assisted treatment. Heroin-based treatment with only 3% is not important beyond the symbolic meaning, but look at the 10%. The 10% who are abstinent, they are in great dangers. I come back to that. Carlos North and Rudi Stoller observed all opioid addicts entering treatment in Canton Zurich. The study was published in Lancet, it's the highest ranking medical publication. The graph shows the overlapping figures of opioid users retrieved in 6 consecutive years and their years of begin with regular opioid use. The peak of the heroin epidemic was in 1992. Their data showed that only 5% of opioid addicts never used opioids again and kept clean for more than 10 years. Moreover, there is no effective treatment against opioid dependence on the long run. They almost always relapse 2 to 4 times. That's 400%. More people die in the first year of the opioid withdrawal than on methadone. When it comes to abstinence, treatment for opioid addiction based on withdrawal and abstinence is wrong and could be malpractice. Thank you.
Oh, thank you so much, Dr. Seidenberg. Very wonderful ideas and conclusions. And thank you. And now our next speaker is Jakob Huber. He's a social worker in Bern, Switzerland, who was basically it's the capital, the federal capital of Switzerland, where they had a large open drug scene. Jakob Huber opened the very first supervised consumption site in a administrative system in the world in the 1980s. He pioneered the idea of integrated harm reduction in his group called Contact Nets Foundation, where he was the leader. He has, I've been enjoying some of his speeches that he's made around the world, relentlessly pursuing pragmatism over ideology. And I've been also in using the tools both of public health and public order. And I'm very intrigued about the battle that has been waged in Switzerland about the meaning of harm reduction, about whether there is a laissez-faire or acceptance model, the abstinence model, and he's come up with a new way to approach harm reduction, which is he calls development-oriented harm reduction. And then basically, if I understand it correctly, it's not just about harm reduction as government doing things for people. It has accountability, and it has the concept of improving people's lives. So very intrigued by the work that he's done and the incredible progressive and very innovative ideas that he's brought. So thank you, Jakob Huber, for being willing to come and speak to Vancouver about your experiences and insights. So please make your presentation now.
Thank you, Sam. Yes, maybe like André said, we had drug scenes in Zurich. We also had a big drug scene in Bern, near the Parliament building. And at the 80s, normal was the attitude of the professionals and also the attitude of the public citizen, that there are two possibilities in drug policy. One is prevention, and the other is repression, like André said as well. So we in Bern, we realized that this doesn't work in our institution. And we realized too, with our approach of saying that you have to be abstinent to go into treatment, we didn't reach 95% of the heavy drug users. So it came up in our institution that contact, that harm reduction that we learned also from the Dutch, for example, something that went on very, very important there, that harm reduction is an attitude, a new attitude, and a new philosophy. It's a change of paradigm. And when we started with open the first safe injection room in Bern, 86, and we started to give clean needles, etc., that was a revolution in drug policy in Switzerland and globally. Everybody came to Bern. Everybody wanted to see what to do. And I have to say, we then had a lot of facilities. I come up with that. And still in Switzerland, we have criminalization of consumption. We have criminalization of all what has to do with deal and drug trafficking. So I would like to give me the picture of the four pillars of drug. You can't go down to the picture of the four pillars.
Can you go down?
Okay, this one, yes. So in Switzerland, we, like André said, we from NGOs, we from general practitioners, from civil society, we came up with this harm reduction attitudes. And that was a real big struggle with all what had to do with police, drug policy and with the citizen. And it ended up in 2008 that the law was changed. That it was 25 years of fight and learning, societal learning. And we have to say that we were fighting for, it is possible you can live with drugs. It is possible, it is not possible to have a society without drugs. And all what we have to do, we have to work for that the people don't be put out of the system. And if they are dropouts, we have to integrate them again. So what you go on, please go on. Yeah, we had go back, yeah. So we had big results in before these 4 pillars came up. When the open drug scene in Bern, when the consumption room was open, everybody was there. So the citizens said from Bern, we think that's better than repression. And we had a big fight within the government and within the society. What is better, to have harm reduction or repression? And also abstinence-oriented therapy. So our success was really drop down of AIDS related deaths, drop down 70% of drug related deaths. The number of opioid addicts dropped down 25%. And what was very important, we had less criminality, 70% less criminality. And for the public, it was very important that we did not have any more this open drug scene. Visibility of drug problems decreased, public safety increased. So please go on. And what is very important, all what we are now listening, or you are listening, we have, after my opinion, we thought there are 4 pillars of what gives us stability of life. If we are healthy, if we have relations, if we have work, we have some income, and if we can live somewhere. So we said an integrated harm reduction is having health interventions with methadone, with heroin programs, etc., needle exchange, but also we have to have counseling, that the people can have relations in their families with friends. And we opened a lot of working places where the people could stay and start to work again and to go back to the normal work. And then we had this problem of people that didn't have homes. So we rented as an institution flats. And we give them the possibility that they can go to live in a flat. And our philosophy was, and our experience, that we want normalization. We want a drug user is a human being, and it's normal. He lived until 15, 20 years in a family. We have to go back to normality, integrate them, and not to put them in a ghetto. That was very important. We had all the people here, because Bern was very, very progressive. Even from Zurich, they came in our safe injection room. And so we had too many people. So we started to think about having other communities, other towns. We went politically, they had to open drug consumption rooms. They had to open low threshold methadone and heroin program. They had to give work to the people. They had to give, and no, not at all to put them somewhere together. But that doesn't work. That makes it worse. That makes it worse because it's a culture. And decentralization was very, very important. And it's also against stigma. You know, if they are in a place, everybody can say, okay, these are the users. And I talked with Sam about that. And I say, our experiences, these drug users, these users, they have relations. They will have children. They have children. What are you doing if you are only in one area? And so everybody has to take over the responsibility. The community have to take over the responsibility for their kids, for their citizens. Okay, so this was very important for us. And go on, one more about the police. Like André, go back to the police. Like André said, we had a police at that time. They were very repressive. And on the social work and the medical part, here in Bern, I think in Zurich, partly it was same, police for us, for my social workers and nurses and also medical stuff, they said they are our enemies. The police said to us, you are all drug addicts. And so it was a fight. So I said, like the director of Contact, this can't go on. So our mayor, that was very important, and it is very important to have a structure, to start to think together about the problem, to start to analyze a problem. All people, all institutions that are involved, the mayor said, he was a friend of mine, he just passed away, that's very pity, but he said, I will make drug commission of Bern. So I was in this drug commission, police was in the drug commission, other institutions were in the drug commission administration, and we discussed, and we had on a high level, we had this drug commission that was political, and on the operational level, that was a harm reduction group. And the harm reduction group also, the police from the street, the social worker, etc. We talked together and said, okay, this could be a possible issue to solve the problem in the city. And we came up that the police become our best alliance that we had in Bern. Social and medical institutions are responsible for medical and social integration. And the police said, okay, we agree. They realized they were on a dead end with their methods. We agree that we are only responsible for public order. So if you want to have public order, we said, you have to give us service to the political people. You have to finance services. You have to see that they can live in a flat. You have to see that they can work. And so came up a very good cooperation between the police and the social and medical institutions. So they are our best alliances. So I say we are fraternal twins. We need each other. And so this was a big gap when the police changes and our people, I say to our people, police are normal people like we. They are fathers, mothers, etc. We can talk with them. So this was quite a long process, maybe 15 years until we came up with that. So this is more or less what I wanted to say to you, and I'm very interested in your questions. I think what we did in Bern, you see, this is a structure. We have a drug commission of Switzerland. We have a drug commission on the canton. That would be British Columbia. And we have a drug commission of the city of Bern. And then we have the NGOs. And the NGOs, like Contact, we have a contract with the city and the canton and the state of what to do. We discuss it, what to do. And then we have the money, they are financed by contracts, and this functions very good. It's always with conflicts, but there's a lot of confidence, a lot of also discussion. And finally, you have to have a good structure. And to come back to the beginning, I think that harm reduction is really the possibility to see realities. how they are. And if Sam that I was creating, that was a big fight in Europe between, are we now abstinent orientated or are we acceptance orientated? And the Germans, harm reduction people said, we accept what the situation of the drug users. And we had a big fight, a big political fight, and also in the mass media, and about 20 years and or 15 years. And I said, I don't, in my institution as well, I don't want this anymore. I want that we go away from this discussion. And I came up here for this reality, political reality and institutional reality, to say development orientated. That means we take the person where it is and we start what she wants to do, and we start to talk to the people. And our experience is it is possible to improve the situation, to stabilize and to improve. And this is our experience without pressure. That means you don't have to do it, but you have to see that if taxpayers pay the services, you have also to see that's not just like that, that you have to, as a user, you have to say, that's not bad. We like that. And for that, we are also doing the best. I just give you an example about that. We had all these syringes, and I went out in the streets in the park where a lot of drug users were, thousands, 1,000 also, and from all over, from Geneva, Lausanne, everybody came, and these cities, they liked that we had an open drug scene because the people came then to burn. So one time, these syringes lie around in toilets, in public toilets, in the parks. Even mothers with their children couldn't play anymore there. And I said, we have to change 1 to 1. If you can't bring one, we give you one. But if you bring 100, we give you 100. It's new syringes. So my people said, no, Jakob, this is like in a bank or like in the military. And I said, we will not, we can't do that with our city. So I asked the users in the consumption room, and they said, we are like that. If we don't have to bring back, we will not bring it back. So please, we don't want to bother you, the city. So please change the syringes. This was all a process. There's a big process going on to change the paradigm of how to work with the police, how to come together, and how to integrate these drug users, because they are normal people. They have just a drug problem, like others have an alcohol problem. And they have still other problems, housing, etc. But we say they are people. They are normal people like you and me, and they want to live. They want to live. If you ask them here, they want to have a flat, they want to have a car, they want to have TV, they want to go to work. Normally, they want to go to work if the work is good. And so we started to build up this network and integrate them in a normal life again. Thank you.
Thank you so much, Jakob. Both of you have accomplished something incredible, which is seeing something like we have in Vancouver, the downtown east side, and you no longer have it. And I'm so intrigued by what you've done and the approach you've taken. I've got to say that the harm reduction model doesn't have as good a name right now, because there's a perception is harm reduction is being tried and there's not a success. And I'm just going to say, Jakob, I know we spoke about Vancouver's approach, which was have people all in one area. And then the other one we're doing now is putting, 100 people in each building in different parts of the city. And Jakob, you said your preference is one person with an addiction per building. And so, you know, I think your whole idea about, you know, getting people integrated into normal, regular, healthy, mixed societies. Now, we have some people who have questions. And what I'm going to do, because I'm worried about time, I'm just going to have, I'm going to read out a couple, and then I'm also going to have some of the people who've asked to speak say their question. So we'll just get those all out right away, and then you can reply after they've discussed that. John Jacobs writes, please discuss the cost. Did police costs reduce as a percentage of city costs, of canton and state costs? And then another question was, is the program involuntary? Because that sometimes affects the way that it works. Now, and we also have Judy Graves. I think Judy would like to have a question. Lynn, can you put Judy?
In Vancouver, we have strong legal advocates who are working on people's right to sleep outside and the right to use drugs. And I'm wondering whether Switzerland was encountering that kind of opposition.
And maybe then we'll just have Scott McDonald also had a question. Scott, do you want to, and we'll put all these questions out there and then you guys can respond. Scott, did you have?
Sure. Thank you, Sam. I'm a general practitioner, prescribed heroin at Crosstown Clinic here in Vancouver today. It's so limited available, though, the options for people. And I'm really impressed how you brought together our federal group, your federal groups, the regions and mayors and city to bring change. And I think you were right on. That whole team needs to come together. And I'd like to hear your story, or if you could reinforce how you did that, because it's pretty amazing.
Okay, so you heard a few of the questions. Are you able to respond to some and all?
Can I ask the first question? I didn't get the sound.
Oh,
The first question was about legal obstruction of the harm reduction measures. There is a popular vote culture in Switzerland. We vote about everything, and there were several popular votes, local and cantonal and federal votes. So there was a public opinion making, and legal obstruction have been there, but they were not very important. They were not effective. The second question about prescription, I think it's very important to give a very clear, controlled prescription or dispensing, to have a very clear control about it. You have to adjust the control individually and systematically. So you meet the needs of the clients, but also meet all the needs of safety and society.
Can I answer to the costs? There was a question about the costs and involuntary. Everything is voluntary in our if you don't have a crime, then it's all treatments are voluntary. And on the cost, you see, we have probably in Canada, you have the same. We have this social welfare state. And the social welfare means if I don't have the possibility to work, or if I have problems, I don't have a house, etc., I go to the administration, the social service of the city, of the community, and there's a social worker, and he says, oh, okay, how do you live? How much do you, where do you live? How much is your flat, etc.? So they make a budget. And this budget, I become it's low, but you can live on, and it's everything. It's you can live on that. So our intervention was for the heroin and for the methadone and all what is medical. We have health insurance, and for housing and for work we have social welfare money. So we said, if we have these flats, our organization, we are renting flats, and the people don't have to go to another flat. So give us this money. If they come to work, give us the money that they need normally if they don't work, and give us a little bit more. So there's a motivation for them to come to work. And in Switzerland, it's still like that. Most of the people want to work. It's a culture of, and if you go in Switzerland and you say, I don't have work, it's quite difficult. If you go and say, I'm working now in this part, even if I work in contact, you are working, that's nice. So you have a, so we become the money from social welfare. It's like a little bit like an insurance.
Thank you. Is Julian Summers, I didn't know if he's on, Julian, do you have a question as well? And I should also ask, there's other questions about housing policies, and when Vancouver has this, you know, as you say, ghetto, and we have putting people in one building, but if Julian's available.
Thank you, Sam, and thank you for this really remarkable presentation, very heartening as well. My main comment is to say thank you and express my pleasure. I was introduced to the work that you've described by my mentor in Seattle many years ago, a psychologist named Alan Marlatt, who made his own contributions to harm reduction, and I was the beneficiary of some of your work because it helped to inspire so far Canada's largest randomized controlled trials investigating ways to respond to homelessness. And we had studied your success, and one of the principles of the most effective intervention that we tested was that not more than 5% of the units in any given building could be taken by our clients. And this was also paying homage to the principles of social integration that you described, and that are also, by the way, for readers, also enshrined in Portugal's national strategy, which for me quite memorably states there is no such thing as addiction treatment without social reintegration. So we have now in Canada remarkably strong evidence, far stronger than the evidence that you would have been able to refer to in making the case for change. And yet in our instance, it has been completely ineffective. And I'm interested in your reflections on the need for persistence and patience, and how you experienced any kind of tipping point. Because so far in our milieu in Canada and in BC, I've presented this type of evidence before, and it doesn't result in any meaningful change. So I reflect on stages of change, and sometimes we have to go around and around, contemplation, action, many times before anything sticks. So I try to adopt a philosophy of resilience. But are there any key points that you could say to encourage us to persist in these efforts, and where you began to see some evidence of traction and an embrace, a sufficient public embrace of what you're describing? Because we are still waiting for that moment. Thank you.
I think yeah.
No,
André?
please go ahead. Yeah.
Okay. Look, this is quite a difficult issue that I say now. All what we know, all the studies we do, also about climate change, very, very few is changing. We know too much, and we're still putting a lot of money in studies, research. Sorry when I say that. And what we did, André in Zurich and colleagues in Zurich and us in Bern, we just did it. We just started. We just, you know, if the tipping point is, you have to have a burden somewhere. The people in a community say, okay, this is not right. This does not work. We want this situation anymore. And then you have to have a solution. Then you have to do something that is different. That is different, and that shows a result. When André opened this methadone clinic, a lot of people went there. A lot of people. When we opened also methadone or safe, like I said, safe injection room, then if you do that, the society, the politics have a moral problem. They have a moral. Our director of the police in Bern said, close the safe injection room, just close it. The Minister of Health, he said, and Social Affairs, he said, no, that's good. And the people who are living in the park, near the park, and could go into the park when we were open, they said, that's fantastic, it's different. So the tipping point is, you have to spring, if the window is open, you have to spring in and do something that helps for the users and for society. That's important for the citizen. They have to see, yes, it's different.
Harm reduction for the community also.
Yes, yes.
There's other questions about the drugs being, are they taking the drugs and selling them for, legal ones and selling them for more money? And also there are groups that want regulation, legalization, fentanyl, cocaine, methamphetamine, normalizing this use. Do you have any comments about that?
Yeah, one can talk a lot about, this is a broad field again. I would like to emphasize that the most important thing to my view is that opioid addict has no other choice than seeking opioids. If you fulfill this basic, for him, basic desire, this is crucial. More than half of the opioid addicted people don't need any further help. They are happy with that if they have an easy possibility. So you need to control it well and to make it easy for them to cope with this crucial point. All the rest is, to my view, I'm a physician, to my view, it's normal social work and policing and all this stuff. About a quarter of the population is not able to cope with any help we provided to them. But when you have a surrounding which is not as problematic as it was before, they won't engage in illegal activities anymore too. They have not the field to do it as they did it before.
Just
Jakob, do you
one
have
thing about,
yes. Okay.
yeah,
If you have
about
any
the regulation or and decriminalization, we are fighting for that since 35 years. We think, we are convinced, I think methadone and heroin substitutions are is a good regulation. And we think that, our experience is that there is no more liberal market than the black market. So we have to regulate all drugs legally. And we are fighting for that, decriminalization and regulation for all drugs. So the people know what they consume and they can integrate them into possible regulations. For that, for the moment, we don't have decriminalization of consumption. We don't have regulation. We are trying with pilot projects for regulation of cannabis that is coming up. You are further on. We were very good in services on harm reduction, but we are not yet good on regulation of the market. And we are fighting to change this system. And yes, the only thing we have for the moment, and we started this in Bern as well in 1996, the first drug checking. So people can come and see what they bought, and we go to parties. This is a possible prevention on bad consumption, etc.
Thank you, both of you. We have been very clear with our urban lunch. We try to not go past one. We've already gone past that. It's the tragedy of the urban lunch is that there's only 1 hour. But what you have done is you've started thinking, started us discussing, and I cannot thank you enough for being willing to join us and to share your wisdom and insights. And we'll probably be able to continue this conversation with some of the interesting questions that are coming up even now. So thank you everyone for participating, and thank you Jakob and André for being a part of this and helping.
Thank you very much.
Thank you for the opportunity. Good night.
Thank you so much.